pain was inevitable, usually uncontrolled. Enough so it interfered with their activities. Of the OA population, an estimated 45% to 80% have undertreated pain. Here are a few examples of what happens if your patient's pain is not controlled. There could be problems with the immune system, complications from lack of mobility, a longer stay in the hospital, which means more healthcare costs into the billions nationwide. So how are we doing? By looking at these recent numbers, you can see there is much room for improvement. To start better
Sounds
controlling
just
your
like a
patient's
news
pain,
editor.
I know, you
Fox
seem like
News.
those people on Health Professional. I know.
pain at home, and what works best for them. Consider mental health and any underlying issues. Realize patients show pain differently than you or I do. Consider on an individual level how your patient expresses pain. For patients that are cognitively impaired, look further and seek insight if available. For example, watch for behaviors and ask family or those close to your patient about what to look for if their loved one is in pain. Consider what your patient is experiencing physically that may be causing pain and treat it appropriately if they're not able to express themselves. At UF Health, the pain rating scale goes as follows. Mild pain is a 1 to 4 and impacts mood and interpersonal relationships. Moderate pain is 5 to 6 and interferes with sleep and the ability to ambulate. Severe pain is 7 to 10, interferes with all aspects of life. To be effective though, this scale needs a good nursing pain assessment. The FLAC pain assessment tool is often used for assessing pain in cognitively impaired patients. While it is a useful guide, it needs true assessment skills by healthcare providers to be beneficial. Pain control is not a new thing. In 2001, the Joint Commission approved standards for acute care pain management to take effect. That means not only does pain control improve patient outcomes, it is required by the Joint Commission. Their standards include recognizing patient rights, residents or clients to appropriate assessment and management of pain, conduct pain assessments initially and during their hospital stay, and educate them. Pain management barriers are there, almost constantly when trying to manage pain. Some are internal within ourselves and some are external in regards to the patient themselves and other members of the healthcare team. Some barriers can be overcome and others need additional decision makers to make changes. Despite our best efforts, more nurses often experience obstacles in pain management, such as being too busy with another patient, patient's family member, assisting a physician, and the list goes on. Can you relate to any of these? Perhaps all of them? Ask coworkers and supervisors for help. If that doesn't work, seek out your nurse manager to come up with a plan or possibly patient assignment changes to better manage a challenging pain problem. The same is true if you find yourself struggling to get a physician to assist you in orders for pain control. Look to your resources. Patients with substance abuse. Researchers say despite a high tolerance for pain medication, if the patient is in pain and treatment is withheld, you are causing harm to that individual. Watch out for pain medication myths. For example, the patient was sleeping, but when woken up, they are suddenly in extreme pain. Pain is whatever the patient says it is. Drugs are not always the best relief, and when used in combination of mechanical relief, such as heat or cold, can provide greater pain control. Try using the moist tea or ice packs if clinically indicated and doctor approved. You may find you need fewer narcotics. Drug-seeking behavior. There are 5 distinct conditions associated with drug-seeking behavior. They are addiction, diversion, pseudo-addiction, obsessive-compulsive disorder, and somatoform disorder. Does the patient fall into any of these categories? If so, communicate with the physician. There are other medications that are not narcotic that help with pain relief. Communicating with the physicians over unrelieved pain despite narcotics can open up options for adding medications such as NSAIDs, antidepressants, anticonvulsants, and stimulants if clinically appropriate. There is belief that giving patients narcotics will turn them into addicts or increase their tolerance for pain medications. Studies have shown that fears of becoming addicted are exaggerated and do not mean pain should not be relieved. If patients are being treated for a specific acute medical treatment and are in pain, they should not become addicted. In the hospital setting, respiratory depression can occur with opioids. However, respiratory depression should not occur if the patient's opioid dose is matched to their pain level, and a skillful assessment is conducted. Administer the right drug to treat the right level of pain. Assess the pain score. Match the score with the right medication. Know your patient. Patients respond better to certain medications in that group. Ask them. Just because it's an IV pain medication does not mean it's the most potent. Using IV morphine as a comparison to common pain medications helps define the different pain management properties of the different narcotics. It may help to share this information with your patient. Know your patient and know yourself. Pain, like I said, is what the patient says it is. Recognize barriers. If you have a group of patients requiring medication so frequently, you cannot physically fulfill their pain management needs without sacrificing the needs of your other patients. Get assistance from your coworkers, supervisors, physicians, and pharmacists, and come up with a plan that better meets the patient expectations and the demands of your time. Hopefully this presentation expanded on what you already know about the importance of pain management, assessment, biases, non-pharmaceutical interventions, and the different types of pain medications available and clinically indicated. And if necessary, the importance of using your resources to help get a handle on your patient's pain if you need help. Pain management is all of our responsibility. Thank you so much for your time.
Excellent
Wow.
job.